Our next speaker earned his medical degree from the University of the East Ramon Magsaysay Memorial Medical Center, where he also currently serves as an assistant professor and was awarded Outstanding Alumni in Medical Education and Best Teacher in the Clinical Sciences. He did his residency training in internal medicine at Cardinal Santos Medical Center and his fellowship in endocrinology, diabetes, and metabolism at St. Luke's Medical Center. He is a fellow of the Philippine Society of Endocrinology, Diabetes, and Metabolism and a member of the Board of Regents of the Philippine College of Physicians. Our speaker will talk about anabolic steroids in sports. I now give the virtual floor to our speaker, Dr. Juan Maria Ibarra, OP.
Hello and good day everyone, and thank you for joining us for the 2021 Annual Convention of the PSEDM. My name is Dr. J.M. Ko, and for the next 30 minutes, we shall be talking about anabolic steroids in sports. I have no disclosures for today's topic. We begin with some definition of terms. Anabolic androgenic steroids, or AAS, refers to synthetic derivatives of testosterone. Androgenic means masculinizing, and that refers to the stimulation of the growth of the male reproductive tract as well as secondary sex characteristics. Anabolic, on the other hand, refers to tissue building, and it's the component of a steroid which is responsible for the thickening of the vocal cords, enlargement of the larynx, increasing libido, linear growth acceleration, that's before epiphyseal plate closure, increasing muscle bulk and strength through dose-dependent hypertrophy, as well as decreasing body fat. Performance-enhancing drugs refer to agents that are used to attempt to enhance athletic performance, and in case of weightlifters or bodybuilders, also to enhance physical appearance with the goal of appearing leaner and more muscular. Doping, on the other hand, refers to the use of banned substances in competitive sports. And just a brief history of testosterone, some more than 6,000 years ago, farmers were already noting an enhanced ability to domesticate castrated animals. It was easier to domesticate them when they were castrated. By 1849, Arnold Adolf Berthold castrated roosters, and these castrated roosters had combs that were increased in size. They also lost interest in the hens, and they lost their aggressive male behaviors. By 1896, Oscar Zoth and Fritz Pregel self-injected testosterone from bulls and measured the strength of their middle fingers. They actually won the Nobel Prize in Chemistry for their discovery. That was later in 1923. By 1935, Carolee David isolated testosterone, and he also coined the term testo from testes, ster from sterol, and on from ketone. So testosterone was born in 1935. In the 1930s, experimentation was already ongoing using humans involving testosterone propionate and methyl testosterone for treating hypogonadism in men. A decade later, by the 1940s, bodybuilders and athletes were using testosterone to increase muscle mass and to intensify training. Generally began in the United States of America, but later on picked up quickly by Soviet Union, and East German Olympic athletes were already using the same agents. And they later found their way into the hands of Olympic competitors, including track and field athletes from many countries. One such athlete is Heidi Krieger from East Berlin. At the age of 16 in 1981, her coach was giving her these blue pills in addition to the vitamins that she was taking. She didn't know that they had anabolic androgenic steroids. 5 years later, she was winning gold in the women's shot put category at the European Athletics Championships in Stuttgart. And 3 years later, even when the Berlin Wall fell and the Cold War came to an end, Heidi was still a high-performance athlete. However, 2 years later, at the age of 26, she ended her career because the doping substances have taken a toll on her body. By 1995, Heidi experienced a turning point in her life. A friend and co-worker explained the inner turmoil that she had been facing. He gave it a name, transsexuality. And by 1998, Heidi Krieger was now Andreas Krieger, a process that took 3 years. The decision to live as a man saves his life. By 1982, Hollywood released two movies, Conan the Barbarian and Rambo, inspiring a whole generation to get buffed up. In 1988, there was the establishment of the Federal Anti-Drug Abuse Act. Androgenic anabolic steroid distribution was now considered a felony offense. 1990, we had the Anabolic Steroid Control Act. According to this act, anabolic steroids had to be placed into the Schedule III category of the Controlled Substance Act. So much so that in the early 1990s, several companies had stopped producing anabolic androgenic steroids. Because of this, black market sales increased. It was now easier to sell these products through the internet. Counterfeit products also increased. In 1994, we had the amendment to the Anabolic Steroid Act. Anabolic steroids, as well as their precursors, were now placed on the controlled substance list, meaning that possession without a prescription was considered a federal crime. And less than 10 years ago, in 2012, a high-profile athlete, Lance Armstrong, had to be retroactively stripped of his titles due to use of performance-enhancing drugs. We present the scenario of a 23-year-old nephew of yours who approaches you during a family gathering. He is interested in using anabolic steroids after seeing its effects among his gym mates. He knows you're an endocrinologist, you specialize in hormones, and he asks about the benefits and risks of using these agents. He also asks if there are ways that we can avoid the side effects of these agents. And the reason I choose to present the scenario in this manner, a relative seeing you at a family gathering rather than a patient coming into your clinic, is because athletes, bodybuilders will not consult physicians on use of anabolic androgenic steroids. You know who they're going to ask? They're going to ask their gym mates, their coaches, their friends, people who have experience using testosterone and its derivatives for anabolic androgenic purposes, not the doctors. Most likely, they will only see a doctor after developing adverse effects from taking these agents. There are many available anabolic androgenic steroids in the underground market that are delivered through numerous routes. We have transdermal routes such as testosterone gels and patches. Pellets are inserted subcutaneously. There's even testosterone buccal system. Some of them are injected, such as testosterone propionate, enanthate, cypionate, undecanoate. We have nandrolone, marketed as decadurabolin, boldenone, marketed as equipoise, methanolone. We have oral preparations, oxandrolone, methandrostenolone, fluoxymesterone, oxylmetholone, and there are other preparations that can be given through multiple routes, whether orally, buccally, sublingual, or injection, or even pellets. Some of the common ones used, trenbolone acetate and stanozolol. And with all the different preparations, we wonder how bodybuilders or athletes choose the agents that they prefer to use. And I guess it depends on what they need. For example, for non-athlete weightlifters who just want to build their bodies, they use boldenone a lot, they use a lot of trenbolone, they use nandrolone and testosterone. Whereas competitive athletes would rather use testosterone mostly. A lot of them will also be using stanozolol and nandrolone. I conducted an informal survey among friends of friends, among patients on what steroids they used here in the Philippines. Most of them are bodybuilders. I wasn't able to find an athlete who would actually admit to using steroids here in the Philippines. And these are some of the agents that they use. One is stanozolol, they call it Stan, it's widely used. Others would use testosterone enanthate or trenbolone acetate or boldenone. Some would use nandrolone decanoate, they call it Deca. Some would actually inject testosterone isocaproate or sustanon. And I asked them, how do you get your steroids? And one of them answered very simply, just find the biggest muscular dude in the gym and kindly ask him. And I like that he's had to say kindly ask him as if we would rudely ask the biggest muscular dude in the gym. And that same patient says he now homebrews his own testosterone and makes it himself. I wasn't able to ask the details on how it's done, how he got the formula or the materials that are needed to brew testosterone, but we know that some of them will be making it themselves in their homes. Others would buy it online, and there are some local stores that sell them, although probably underground and in secret. So I checked online, went to the shopping website, this very orange website, to see if it was just easy to buy testosterone over the internet. I searched for stanozolol, and what would you know? There is a seller for Stano 10, that's stanozolol 10 milligrams. This is from Gaines Lab. He's selling it for 1,285 pesos for 100 tablets. And looking at the product description, he has ratings. This is out of 5 for muscle gain, that's 3 out of 5. Fat water loss, just 2 out of 5. Side effects, 3 out of 5. And keeping the gains, 3 out of 5. And the dose is written here, 20 to 50 milligrams per day. Product rating for this particular seller, 4.7 out of 5. Seems that his customers are happy with the products they buy from him. So probably genuine or legit. And if you look at the other products from this seller, you'll see that he has a wealth of products for anabolic androgenic steroids or performance enhancement. He has Danabol, Stanabol, Sustanon. He has testosterone enanthate. And it's a long product line. This guy's even got testosterone cypionate. He has liothyronine cytomel, apparently that's also being used for performance enhancement. He has agents that might combat the side effects such as tamoxifen or clomiphene. Really a lot of products. There's actually 5 pages worth of products just from this store alone. And you'll see he's been selling several products, 20 sold, 30 plus sold per item, and very high ratings for his products. So I was curious where the seller was sourcing his products. So I went to the website of Gaines Lab. That was the brand that was indicated in the products he was selling. I wanted to find out what country they were from, and I couldn't find anything on the website on where it was produced. We know that no authorized laboratory or accredited laboratory will be allowed to produce these products. So these are all underground laboratories or manufacturing sites that produce these agents. And if you see in the bottom, there's an authenticity verification. You enter 2 lines of code and check if the product that you have is authentic, which probably means that the market is flooded with these inauthentic or fake products of testosterone. In that Gaines Lab website, see this long list of parenteral products that are being sold, each one with its own description on the strength, muscle gain, fat and water loss, side effects, and keep gains. And I guess it depends on the needs of the bodybuilder or the athlete, whether they prefer more strength or muscle gain, whether they want to use it as fat or water losing agents, whether they can tolerate the side effects and keep the gains for a longer period of time. There's also a lot of oral products from oxandrolone, clenbuterol, oxymethylone, stanozolol, methandienone, liothyronine is also used as a performance enhancing drug. And they have other agents also, human growth hormone, recombinant IGF, mechanogrowth factor, growth hormone releasing peptide 6, and even the sterile water that they need to mix these peptides so that they can be injected. And these are different patterns of use of anabolic androgenic steroids. There's something called cycling, where multiple doses of steroids are given over a specific period, then they're stopped for a period and then restarted again. I went over the comments in the seller's page and I saw that people commenting about, I'll be starting my next cycle soon. Thank you for delivering this product. I'll be taking it for 12 weeks and then stopping for another 6 weeks and then restarting it again. There's something called stacking, where 2 or more different anabolic steroids, sometimes a mix of both oral and injectable types, are taken by patients. There's something called pyramiding also, where the dose is titrated up and then tapered down in 6 to 12 weeks. That helps people avoid the side effects of the steroids. And there's something called plateauing, where the doses are staggered, overlapped, or substituted with another type of steroid to avoid developing tolerance. And with regards to the efficacy of androgens, there really is a paucity of clinical data on this topic. One such study includes 43 normal men who were randomly assigned to receive either strength training exercise and 600 milligrams of testosterone enanthate once a week. That's about 6 times replacement dose. Another group received strength training exercise and placebo. Another group received no exercise but got testosterone. And the last group got no exercise and just got placebo. The results of this trial: testosterone treatment increased fat-free mass and muscle strength, both in men who exercised and in men who did not, but more so in those who exercise simultaneously. So testosterone will really build that muscle strength and increase fat-free mass, even if patients don't exercise. Another study looked at 61 healthy eugonadal men treated with a GnRH agonist to suppress endogenous testosterone secretion. They were randomized to 5 groups. Either they got weekly doses of 25 or 50 or 125 or 300 or 600 milligrams of testosterone enanthate. The results: testosterone administration was associated with a dose-dependent increase in leg press strength and leg power. Improvements in strength and power correlated with serum total testosterone concentrations, although muscle fatigability did not change with treatment. And some studies on androgen precursors: androstenedione 100 milligrams 3 times a day for 8 weeks did not increase muscle strength. Androstenedione or androstenediol did not alter body composition or muscle strength compared with placebo. DHEA versus androstenedione or placebo, there were no differences in fat-free mass and muscle mass between groups, although DHEA in men, but not women, was associated with increased knee and lumbar back strength compared with placebo. How about the effect of growth hormone on fit young adults? This is a meta-analysis on the effects of growth hormone treatment versus placebo. On the top panel, you'll see no significant difference in the relative change in muscle strength between the growth hormone and placebo groups. And in the bottom panel, you'll see the weighted mean difference in maximum oxygen uptake. Also, no significant difference between the growth hormone and the placebo group. Looking at growth hormone effects on physical performance, you'll see in the left graph that patients who received growth hormone instead of placebo actually fared poorer in dynamometry or measure of strength. They did improve a little bit on jump height, and they did improve significantly in the Wingate test, which measures sprint capacity. But if you look at the placebo effects on physical performance, some of these patients on placebo thought they were receiving the active drug, while some knew that they were on placebo. And just the thought that they were on the active drug actually increased measured performance in terms of VO2 max, deadlift, jump height, and the Wingate total work in joules. So maybe just the thought that you are on an active drug, even though you aren't on it, the placebo effect is enough to improve performance with growth hormone. So we're not sure the effect is just from growth hormone or just the placebo effect, knowing that they are receiving the drug. How about for erythropoietin? There are consistent and positive effects of recombinant human erythropoietin on maximal oxygen uptake of about 6 to 8% or 300 to 400 ml O2 per minute when moderate doses of recombinant human erythropoietin are administered. In cycling, this improvement may be translated in an increase of 25 to 35 watts expressed at maximum aerobic power, and in running, the improvement of about 6% in 3-kilometer time trials has been observed. And these forementioned effects appears to be elicited even with just microdoses of recombinant human erythropoietin. And although we've seen benefit in terms of use of anabolic androgenic steroids when it comes to improving physical performance or improving physical appearance, there is a price that has to be paid for these benefits. And that price is quite high. it may exact a toll on an individual's health. And this document from the Endocrine Society, the position statement on steroid abuse published in 2008, might be a good way to start a discussion with your patient regarding this. And it's easy to understand. There's this paragraph here that says that anabolic steroid abuse in men can promote breast development, acne, hair loss, and enhanced aggression. In women, anabolic steroids can promote the development of more masculine features such as facial hair and a deeper voice. More alarming, anabolic steroid abuse has also been strongly associated with cardiovascular diseases including heart attacks and strokes, even in people younger than 30. Pharmacological doses of anabolic steroids, particularly when taken orally, increase LDL, decrease HDL, and oral anabolic steroids have also been linked to liver disease. Many users are aware of the short-term consequences, the acne, the hair loss, the gynecomastia, but many are unaware of the long-term consequences, including that of increased cardiovascular diseases. Locally, I asked our bodybuilders what side effects they noted. Many of them said fluid retention was a big problem. This can present as edema or muscles looking soft or bloated. Some of them got acne, although it was rare. A lot of them would get gynecomastia. Some would get hot flashes, especially with high doses of steroids or when they'd stack steroids together. They had insomnia. They called it trensomnia because it was seen in users of trenbolone. They saw increased libido, aggressive behavior, and some of them even noted that they were becoming moody when using testosterone. The study looks at reported physical and mental health problems seen in users of androgenic anabolic steroids. For the physical health, maybe 40% would get problems with sexual function and even appearance. Some would have problems with their musculoskeletal system or even cardiovascular system. But what's more important is the mental health issues, which are more prevalent. About more than half got depression or behavioral changes. Nearly half had sleep problems or anxiety. Some had dependence, and about 10% had aggression and anger, and jealousy and paranoia as a health problem. They also interviewed the next of kin and asked what were the observed changes in these users. Up to 80% said there was a noted change in behavior. 40+% noted anger and aggression in the users. Almost 40% depression. 30% decreased empathy. Some would get anxiety, sleep problems, even suicidal thoughts, excessive jealousy, and dependence. And to understand how bad steroid rage can get, there's the story of WWE professional wrestler Chris Benoit, who, together with his wife and son, were found dead in their home in 2007. Their deaths were a murder-suicide that began over the weekend. Benoit allegedly killed his wife and son and hanged himself. They found steroids in Chris Benoit's home, spurring speculation that the so-called roid rage may have been a factor in the murder-suicide that occurred. Abuse of steroids may have multiple side effects. We don't know the exact prevalence rates of these side effects because we don't have controlled studies. These are generally from case reports and case series. If you have a friend, a relative who's interested, maybe show them this figure. There are many side effects that might be associated. The risks may actually be higher than the benefits that you'd intend to get. In 2013, the Endocrine Society published a scientific statement on the adverse health consequences of performance-enhancing drugs. This is the table for anabolic androgenic steroid use. We'll see here that dyslipidemia is common. Cardiomyopathy, this was seen in autopsies of patients who died while taking anabolic androgenic steroids. They saw myocarditis, they saw left ventricular hypertrophy, and other physical abnormalities. They also saw cardiac conduction defects, coagulation problems. Polycythemia, we know, is common in testosterone use, hypertension. Of course, there was suppression of the hypothalamic pituitary testicular axis, and there was hypogonadism when they withdrew use of anabolic androgenic steroids. The females, neuroendocrine also. A lot of mood disorders, mania, hypomania, and depression. Dependence is also a risk factor, and other hepatic, musculoskeletal, kidney, and immune suppressive effects. Derma, acne, and striae can also be adverse effects with use of anabolic androgenic steroids. For growth hormone, cardiomyopathy, and diabetes are adverse effects commonly seen. For erythropoietin use, thromboembolic events, increased risk of strokes and cardiovascular events were seen, even increased risk of death. There are some strategies that are suggested by users, by certain websites, and maybe some literature to avoid or treat side effects. Some recommendations used by Filipino bodybuilders include the use of aromatase inhibitors. These can block the aromatization of testosterone to estradiol, thereby blocking its effect to cause gynecomastia. So they sometimes use letrozole or Femara, anastrozole or Arimidex. These are cancer drugs. They sometimes use selective estrogen receptor modulators such as tamoxifen or clomiphene. And other agents mentioned in the literature can include HCG to counteract the reduction in testicular size, 5-alpha reductase inhibitors to prevent balding and acne, and some diuretics to promote water loss. But again, no evidence that any of these work. It would be very difficult to do a trial recruiting users and giving them these products versus placebo. And one adverse effect that we'd like to focus on is gynecomastia. This is probably the number one reason why you will find users coming into your clinic because they've now gotten a complication from anabolic androgenic steroid use, and that is gynecomastia. Prevalence is about 52% in some studies, maybe a dose-related side effect that occurs primarily with the upper extreme of steroid dosage. So you know if a patient had gynecomastia, then he probably used a very high dose of testosterone. It's usually associated with pain and swelling, but these will resolve spontaneously with cessation of steroid use. And based on the case series, tamoxifen did not prevent or reverse steroid-induced gynecomastia. As we said in the earlier slide, no evidence that agents that are being used in gyms to prevent the side effects actually work. The recommended treatment should be complete steroid cessation, not the addition of new drugs. And some will spontaneously resolve, but for a lot of patients, it will persist, and the only treatment will be surgical. And one article states that the combination of liposuction and direct excision of gynecomastia yields excellent cosmetic results with low risk of complications or recurrence. I've sent many a patient to a plastic surgeon for gynecomastia treatment, and they've undergone successful surgery. And if you find yourself speaking to a user, you might want to discuss stopping the androgens. Men are actually usually reluctant to stop even when they no longer are engaged in the activity for which they took the drugs originally. Competition is over, they won the competition, but they are now dependent on these androgens. A clinician should encourage him to do so, but must also advise that he will likely become hypogonadal for a period. This period can last many months before his pituitary testicular axis recovers. And during that hypogonadal period, they may develop these symptoms of androgen deficiency, such as depression, fatigue, decreased libido, and sexual dysfunctions. And sometimes patients will come to your clinic during the withdrawal period asking what they can do for this androgen deficiency. These men often ask clinicians for HCG or clomiphene to hasten this process, but there is no evidence that either does so. The clinician should also offer to follow the recovery by measuring serum testosterone concentration initially 3 months after discontinuation of the drug, and if the value is not normal, then periodically thereafter. But if fertility is desired, sperm density should be tested as well, also beginning at 3 months. But be careful, because some men may say they want to stop taking androgens as an excuse to get a prescription for HCG. When the clinician does not prescribe HCG, they may not return. And we are nearing the conclusion of today's topic. Just to summarize, anabolic androgenic steroids improve physical performance and appearance. They are banned substances but are easily acquired through gyms and the internet. They are manufactured illegally, and counterfeits are also present in the market. They are associated with adverse effects, some minor, including fluid retention, acne, gynecomastia, hot flashes, insomnia, and striae, but some major, including cardiomyopathy, hypothalamic pituitary testicular suppression, depression, anxiety, mania, hepatic and renal events. There is no evidence that adverse effects can be prevented or treated with other medications. Stopping androgens are essential in the management of adverse events. Stopping may lead to hypogonadism, which may last for several months and can be associated with other symptoms. And gynecomastia may resolve, but some may actually need surgical treatment. And for further reading, you might want to download the Endocrine Society's scientific statement on adverse health consequences of performance-enhancing drugs. This was published in 2013 at the journal Endocrine Reviews. And with that, we'd like to thank you all for your very kind attention and for your interest in our topic, anabolic steroids in sports. Should you have any questions, feel free to email me. My email is jmcomd@uerm.edu.ph. Good day, everyone.
I now award the certificate to our speaker, which reads, the Philippine Society of Endocrinology, Diabetes and Metabolism awards this certificate of appreciation to Dr. Juan Maria Ibarra, OCO, in grateful appreciation for graciously sharing valuable time and endeavor as speaker during the 2021 PSEDM Virtual Annual Convention with the theme Hope, Health Optimization and Progress in Endocrinology. Signed, Dr. Michael L. Villa, Vice President, PSEDM and Chair, Scientific Committee, and Dr. Jeremy Jones F. Robles, President, PSEDM.